Good afternoon. My name is Dr. David Traster. I'm a doctor at the Carrick Brain Center in Atlanta, Georgia, and a recent graduate of Life University. I've been asked to speak to you today for a short time to give you a little bit of a background of the happenings of functional neurology over in Atlanta, as well as give you a short little talk on eye movements, the basic physiology and pathophysiology of eye movements, and how your understanding of how the eyes work and how the brain moves the eyes to help you localize lesions in concussion and in other disorders. Concussion always has a rotation of the head, and everyone is different. So you could have one focal lesion or multiple focal lesions or a little bit more of a global lesion depending on what's going on. But usually you have some focal lesions, and these eye movements really help localize problematic areas from a concussion. And the better you can localize the lesion, the better your diagnostic ability will be, the better your management plan will be, and the better your outcomes will be. So having said that, I don't want to take up too much of your time, so we're going to start getting right into it. Diagnostic value of eye movements and traumatic brain injury is going to be the title of this PowerPoint. I'm not going to read off this PowerPoint, but I will send you the PowerPoint. So hopefully after my lecture, you're able to go to the PowerPoint, and there will be more details in the PowerPoint than in my lecture. And my goal is to give you the basics of eye movements to help you start on your path to better understanding how you could use these for your clinical practice. Eye movements are very important because they're seen in every part of the brain. So vision really uses the whole brain. It's the one modality that uses the whole brain. And your vision is very dictative of your eye movements. So your eye movements are seen in every part of your brain, and each part of the brain has a little different function of what it does. So it really allows you to use these eye movements and different eye movements to really compare what's going on diagnostically and help you develop a good treatment protocol. There are really two types of eye movements when you really break it down to the most simplistic form. You have one type of eye movement which wants to keep your eyes on a subject or a topic of interest. So you have one eye movement that all you want to do is stay looking at something, whether that object is staying stationary or whether it's moving. The idea is you want to stay looking at the object. The other eye movement is to look at something else. So realistically, you have eye movements that keep you looking at something and eye movements that make you want to look at something else. And you could break those down to more detail, but the most basic level, that's what we're really working with. Here are different types of eye movements that we'll be discussing. You have vestibular eye movements, you have visual fixation, you have optokinetic eye movements, you have smooth pursuits, you have a nystagmus quick phase, which is part of the optokinetic system, you have saccades, and you have vergence. Your vestibular system is very important because it's going to be your quickest eye movement. Latency is about 15 milliseconds, and this is really important during head movements or during walking or gait. The biggest threat to your vision is gait and walking and running. When you just walk, not even running, every time you take a step during gait, you have a perturbation from your heel up into your head that's at 0.5 to about 5 hertz. And the only reflex, or the only eye movement that's fast enough and has a short enough latency to compensate is your vestibular system. Your visual system has about a latency of 70 milliseconds, and that's too long to compensate for gait and to compensate for the functions of the VOR, which is the vestibular ocular reflex. We had a very good patient the other week with Dr. Carrick, who was a professional athlete who had a very bad head injury, and his double vision diplopia was terrible. But if he stood still, his double vision wasn't so bad, and his mom couldn't understand how he was able to play ping pong, but the second he moved, his double vision got terrible. And if you looked at his gait, he had a shuffling gait, not because he had pre-Parkinson's, because every time he took a step, he had this perturbation at 0.5 to 5 hertz that created eye movements, and his VOR wasn't fast enough or wasn't intact enough to compensate. So he had to try to compensate with his visual system, and it was too slow. And every time he took a step, he had diplopia. So this VOR and this vestibular system is very, very important for both gait and just moving your head, keeping your eye fixated on a topic or on a subject. Your visual fixation is really important, but it's got a little bit longer latency. But visual fixation is either look at something that's stationary, or a pursuit is really a visual fixation and movement. So what you want to do is compare your VOR with your visual fixation versus your optokinetic nystagmus, which your optokinetic nystagmus has to do with I need to know where my body is in relation to the environment, where the environment is in relation to my body, and where my body is in relationship to itself. So when I move to the left, the world is really moving to the right. And when I move to the right, the world is moving to the left. And it helps my brain have a better idea of where I am in space and where space is in relation to me. And it's really a good function of global brain. And we'll talk a little bit more about that. Your saccades are quick eye movements that are going to bring your brain and your focus from one target to the other target. So it helps redirect your line of focus. And your vergence gives you a little bit of depth because it's the movement that gives you non-conjugacy of your eyes. So you can either open them up and diverge or bring them closer and converge. And it gives you a little bit of a depth field and a depth plane of how your brain can see different depth fields. So for clearest vision, you want your macula of both eyes and your fovea to really be looking at the exact target of interest. For the best vision, you want the target to be within 0.5 degrees of the middle of the fovea. And motion shouldn't be less than 5 degrees per second or else you're going to get blurring. Anything over 2 degrees from the fovea, your visual acuity is dropping by 50%. So if you think about it, if you've looked at the back of the eye, your fovea is pretty tiny. And the middle of the fovea is even tinier, and you have one on both eyes, and they need to be looking at the same exact thing. It takes a lot of brain power to be able to do that because the second these eyes are off by only 2 degrees, you're going to see diplopia and double vision. And you're going to have diplopia and see double vision, to say it better. So you really have a lot of brain power trying to get each eye exactly on target and looking at the same exact thing. So let's just get right into it. How about that? So I'm going to show you some pretty bad drawings, but I think the simplicity of the drawing is going to help bring in my point. So we're going to talk about some basic physiology of eye movements and then some basic pathophysiology of eye movements. And I hope that it's going to help clinically bring light into this topic. I'm going to break this down pretty simple. So what I'm going to tell you isn't going to be 100% true because it's so much more complex. But clinically, what I'm going to tell you is going to hold very true. So we're going to start with the eyes. Most people know about the eyes and the eye muscles, and we're just going to review it real quickly. If you take a look, here's the eye. To AB duct, this way, you have the lateral rectus. AD duct, you have the medial rectus. When the eye is laterally to elevate, you have the superior rectus. When the eye depresses, you have the inferior rectus. When the eye is lateral, to intort, you have the superior oblique. And to extort, you have the inferior oblique. When we go medial, to go up, is going to be the inferior oblique. Medial and down will be the superior oblique. Medial and intorsions, the superior rectus. And medial and extorsions, the inferior rectus. To say it a little simpler, that all superior muscles are going to intort the eye. All inferior muscles are going to extort the eye. And as you look at the eye muscles, so if you have the lateral rectus pulling this way and the medial rectus pulling this way, every time I need an eye movement to bring my eye laterally, not only do I have to excite the lateral rectus, but I need to inhibit the medial rectus at the same time because it's a tug of war. It's like a rubber band that I could pull on this rubber band and this one gets stretched. And the second I let go, it's going to go back to middle. So you constantly have this pull of muscles that are going to want to bring your eyes back to middle. So the second I'm going to want to go one direction, I need to inhibit this guy and let this guy go. At the same time, if I want to hold my eyes to the right, this guy gets stretched on the other side, your antagonist, and it's constantly pulling your eyes to go back to middle. So even just looking to your right is going to be a motor phenomenon. You need motor activation to hold your eyes against the center, against the eye getting pulled back to center. Because when you have like a rubber band, when your eye gets pulled one way, the other one gets stretched and it's going to pull it back to middle. So when we have the lateral rectus, we know the lateral rectus is going to come in and it's going to be innervated by our motor nuclei, the abducens nuclei. And everyone should be pretty familiar with the abducens nuclei. The abducens nuclei, that's going to be your horizontal gaze center. So in order to move, let's say left, let's call this guy left, like he's looking at you, and this guy right. In order to look left and activate the lateral rectus, we need the abducens nuclei to fire to it. In order for this medial rectus to activate, this nuclear 6, which is the abducens nuclei, is the coordinator. It's going to fire up the MLF, hit 3, activate 3, and the eyes are going to go left. These are all some pretty basic concepts you should know. And most people know the motor nuclei, the peripheral nerve, and the muscle. Where a lot of people fail and what they don't know are these pre-nuclear generators and these premotor nuclei, and that's what we're going to talk about today. So we're going to start with horizontal eye movements. We have a slow phase and a fast phase. Right now we're just going to talk about the slow phase, and let's just talk about a VOR. That's our most basic reflex. So if I'm going to turn my head left, my eyes are going to go right. If I turn my head right, my eyes are going to go, ooh, look at that roll. If I turn my head right, my eyes are going to go left. I'm so pathological, I can't even do that. So anyway, so you're going to have a VOR that's going to make your eyes go right and opposite of head movement. The way that works is these little diagonal guys and these diamonds, these are your vestibular nuclei. You have 4 of them, but we're going to keep it pretty simple. We'll say this is the right vestibular nuclear complex, and this is the left vestibular nuclear complex. And what's going to happen is, let's say I turn my head right, or I move my body right, since it's going to be a little easier for me, and my eyes are going to go left. So if I turn my head to the right, or my body to the right, I have a horizontal canal that's being activated. And this horizontal canal, there's a terrible horizontal canal picture. I got a better one on the next one. It's going to fire into this right vestibular nuclear complex, as well as some other places. But this nuclear complex is going to fire over to 6. 6 is going to fire both to the lateral rectus, through the abducens nerve, and then through the medial longitudinal fasciculus, the MLF, it's going to hit 3 and make the eyes go left. And that's your basic VOR horizontal pathway. It's a little more complicated, but we're going to keep it pretty simple. So this is your ocular motor nuclear complex, your trochlear nuclear complex, your abducens nuclear complex. Here is your vestibular nuclei. So right now you should be pretty good at that. Back here is your cerebellum. And then we have these guys here. These blue guys are going to be what's called your paramedian pontine reticular formation, and these are your excitatory burst neurons. These red guys are also the paramedian pontine reticular formation, but they're going to be inhibitory burst neurons. To say it simply, we have 2 types of eye movements. We have a slow eye movement, like a slow phase of your VOR, or slow, smooth pursuit. And then we have fast eye movements, like a quick phase of nystagmus of your vestibular system, your optokinetic system, or a saccade. This vestibular nuclear complex is very concerned with these slow eye movements, whether it's from a head turn or whether it's from a volitional pursuit or whether it's a slow phase of nystagmus. These burst neurons are going to be very concerned with quick phases and saccades and fast eye movements. So we're going to break everything down to, is it a slow, smooth eye movement or is it a fast, jerky eye movement? If you look here, this is the pontomedullary reticular formation. This is for horizontal eye movements. If you look at these guys here, these are in the mesencephalon, the top of the midbrain, and these are going to be vertical eye movement generators. These top blue guys, these are going to be your excitatory burst neurons, and they live in the rostral interstitial nucleus of the medial longitudinal fasciculus, or the RI-MLF. And these are your excitatory burst neurons. These other guys are both inhibitory burst neurons and your neural integrators, which we'll talk about, and that's your interstitial nucleus of Cajal, and that's your INC. Right here is your horizontal neural integrator, and that's going to be your nucleus prepositus hypoglossi, or your NPH, which is very associated with your medial vestibular nucleus. So you have an MVN NPH complex. They're very medial, they're very old, and they really work pretty well together. So that's going to be your basic anatomy. Let's talk real quick about here. Cranial nerve 3, or cranial nuclear 3 ocular motor complex, trochlear nuclear complex, abducens nuclear complex, vestibular nuclei, vestibulospinal tracts, burst neurons, inhibitory burst neurons, your commissure, which inhibits each other, vestibular commissure. Here's your nucleus prepositus hypoglossi, and here's our omnipause neurons. And what we're going to do right now is we are going to, let's see what we're going to do. So we're just going to go through this again. Let's talk about a pursuit. How about that? Here's your parietal lobe, here's your VOR, and here's your canal system. So let's talk about a right VOR. Horizontal canal is going to fire into the vestibular nucleus. The vestibular nucleus is going to send information to the abducens nucleus, which is going to go to lateral rectus through the MLF to the medial rectus, what we just talked about. The kicker is we have a pulse and a step. So when you have a pulse, what it's going to do is it's going to tell the velocity, tell your brain how fast your eyes need to move. So let's actually start with saccades because it's going to be a little bit easier. So when you do a saccade, everybody's at bedside, you move a finger, and the person looks from your nose as fast as they can to the finger. How does that really work? So how it works is you're looking at my nose, your fovea is really pointed at my nose. Everything else peripherally, where's my finger? There it is. Everything else peripherally is going to be more rods, more motion sensors, and it's not going to be the fovea directly back to the occipital lobe. It's going to be a little more peripheral, so you're going to be more superior colliculus in these grids of maps. So your superior colliculus has about a grid, and what it's going to say is you're going to see movement, and let's say I wiggle my finger. Your colliculus is going to say the target was here on the map. And it's going to feed up into your frontal lobe and say you need to move your eyes to a target 20 degrees, let's say. Your frontal lobe takes that information and it says I need to move my eyes 20 degrees, and it converts that 20 degrees into a velocity. So your distance and your velocity are directly correlated, and it says if I need to go 20 degrees, I need to move 500 degrees per second. It then takes that information and sends it back to the superior colliculus and says, move the eyes 500 degrees per second. The superior colliculus comes down, and it comes down into these burst neurons. And it'll go this pathway first, and it comes down to the burst neurons. And what the burst neurons do are they're premotor generators, and their job is to move the eyes fast. So what it says is it gets down the burst neurons, and it says, move the eyes 500 degrees per second. The burst neuron charges up and says, no problem. And it's going to send an output right to the abducens nuclear complex and says, I need the eyes to move at 500 degrees per second. And the abducens nuclear complex sends it through the abducens nerve and moves the eyes at 500 degrees per second. But at the same time, that's the pulse. That's the velocity it's going to take to move the eyes from one target to another target. But then you get to the target, you need to hold the target there. And that's called the step, and that's the neural integrator. So a neural integrator is like a little mathematician. And these burst neurons, as they fire to 6, also fire to the NPH, the nucleus prepositus hypoglossi. And the NPH is this little mathematician who sits in his little chair and does his calculations, and he's going to flip it back around. And he's going to say, at 500 degrees per second, that means I need to hold the eyes at 20 degrees. And he's going to tell the abducens nuclear complex, hold the eyes at 20 degrees. And then the abducens nuclear complex is going to know to go 500 degrees per second and then hold the eyes at 20 degrees. In a perfect world, that's how it works. Now, the neural integrator is the step. The neural integrator is what holds the eyes in a static or a tonic position. The burst neurons are the pulse, and the pulse and the burst neurons move the eyes very fast from one target or one object to the next object. Here are omnipause neurons. Omnipause neurons pause the eyes. So for me to look at you and stay staring at you, I need my eyes to stay fixated and not move. These burst neurons are constantly firing. They're always on. They always want to move the eyes. If you look at primitive animals, their eyes are always moving. They're jerking. The heads are always moving. They're always moving around. They don't have any fovea. They can't fixate. They're constantly looking at motion. Humans have a bigger frontal lobe that really helps us fire down into these omnipause neurons. And omnipause neurons pause the eyes. So omnipause neurons inhibit your burst neurons. So your omnipause neurons are going to come down, and they're going to inhibit all these guys. And they're going to be the brake of the burst neurons. And they're always going to stop the burst neurons. So if you take a look, the superior colliculus, one pathway, it needs to excite the burst neurons and say, go 500 degrees per second. And these burst neurons need to say, go 500 degrees per second, and then talk to the neural integrator and say, neural integrator, we need to move 500 degrees per second. So the neural integrator could say that's 20 degrees, tell the abducens nuclear complex to hold the eyes at 20 degrees. Your omnipause neurons are the ones that hold the eyes steady. So in order to move the eyes very fast, the superior colliculus needs to come down and the rostral pole, and it needs to come down, it needs to come and inhibit the omnipause neurons. So your rostral pole of your superior colliculus is going to be your tonic inhibitor, meaning that the rostral pole up here always activates the omnipause neurons, which inhibits burst neurons. So the top of your superior colliculus is going to activate these omnipause neurons to inhibit burst neurons. So when the superior colliculus rostral pole is active, your eyes should stay steady. In order to move your eyes, you need the nigra, or you need the inhibitory aspect to hit the superior colliculus, allow your eyes to move. Long story short, in order for these burst neurons to fire, we need inhibition of the omnipause neurons to stop inhibiting the burst neurons to allow the burst neurons to fire. Pretty complicated, but it's going to tie in clinically really, really well. So here are horizontal burst neurons. Up top, we have vertical burst neurons that we're going to talk about. So when we take a look at our pursuit mechanism now, we have a pulse, meaning that if my head moves 20 degrees per second to the left, my eyes should move 20 degrees per second to the right to allow a perfect gain of 1, to allow my eyes to stay steady and visual acuity, it should be 100% on a target, depends if my head moves around. So we get a pulse from the canal system into the vestibular nuclei. The vestibular nuclei is going to come up, activate 6, say your head is moving 20 degrees per second. At the same time, it's going to send a step that says 20 degrees per second to allow your visual fixation to hold on to a target. So it's no different. You have a pulse and you have a step. Interesting though, if you take a look at like a left VOR, you have a smooth eye movement to the right. If you take a look at this parietal lobe, and let's say I want to do a right pursuit, it's going to start in that parietal occipital temporal region. We're going to say parietal lobe for now. And it's going to go ipsilaterally down to the pons, contralaterally to the cerebellum. It's going to come over to this vestibular nuclei, and then it's going to hop a train on your VOR. So what your pursuit really is a volitional VOR with your head still, meaning that these reflexive machinery in your brainstem, we use it, it's almost like a primitive reflex. When you're born, you have these primitive reflexes, you don't have a brain. So you're born with reflexes to allow you to move without a brain. And as you develop your brain, as you develop your cerebellum, as you get feedback and feed forward and efferent copy happening, all of a sudden your brain picks up how to move, chops up these primitive reflexes into pieces, and can use them volitionally and start tying them together. Your eye movements aren't much different. You're born with some reflexive eye movements, and as you move your head as a baby and move around reflexively, feedback goes into your cerebellum, into your brain, you have feed-forward mechanisms, efferent copy, and your brain starts using these reflexes volitionally. So your pursuit is really a volitional VOR, the same machinery. Your saccades are volitional quick phases of nystagmus, same machinery, so you could really use it clinically. You could compare your slow phases reflexively versus your volitional activity that uses the same pathways, and compare. If I have a lesion in the brainstem, I would expect both the VOR to be affected and the parietal lobe pursuits to be affected because they both use these same brainstem mechanisms. If my lesion is up in the cortex, I would assume that there might be a better probability that my VOR may be intact, but my parietal lobe's ability to come down, there's a cortical lesion, it can't fire down into the brainstem. If I have a subtle brainstem lesion, maybe the activation from the vestibular system isn't enough for it to be normal, but my cortical activation down might reach a different level of threshold. So let me say it differently. You have a pulse and you have a step of every eye movement. But metabolically, your pulse has different frequencies of firing and different spike trains. So a VOR, more reflexive, might have a little bit of slower activation and a little easier metabolically. And as you go up the chain to a saccade, it's going to be a faster spike train, and it's going to hit that neural integrator differently. So I could take a look at the stability of the neural integrator because I could do a VOR and look at right horizontal gaze. I could do a pursuit and look at right horizontal gaze, or I could do a saccade and look at right horizontal gaze. And I could look at the stability of my gaze holding, reflective of the neural integrator and the step, and see if the neural integrator is intact. If my neural integrator is intact, when I look to the right, my eye should stay right. Traditionally, a neural integrator lesion, you're going to have what's called gaze-evoked nystagmus, meaning that if I'm looking to the right, I have a slow phase back to the middle and a quick phase back to the right. And that's what you're going to see because you have that pull of the other muscle trying to bring it back to the middle. So you're going to pull it back to the middle, and you're going to kick it back out. And that's what you're going to see traditionally on a neural integrator failure. Now, if I could do a left VOR and my gaze is pretty steady, the step is appropriate. I then do a right pursuit, my gaze is pretty steady, it's appropriate. I then do a saccade to the right, and after my saccade, I get a gaze evoke nystagmus. I may be looking at a metabolically fragile neural integrator, and I might want to do some pontine or some integration treatment-wise to that neural integrator at a lower frequency because all eye movements in the horizontal plane are going to go through the nucleus prepositus hypoglossi. So you can rehab a saccade through the neural integrator with any eye movement. You need to look at that metabolic threshold of how you're going to use it. Hopefully that makes a little bit of sense. I'm trying not to take too much of your time, so I'm going to run through this a little bit. If you go to the Life Neurology Club website, we have all this information on there. So you always want to compare your volitional pursuits with your VOR, with your optokinetic slow phase. If we talk about optokinetics, your optokinetics, if you have a slip of the retina, let's say to the right, I'm going to have a mesencephalic reflex that's going to drive the eyes to the right, and I'll have a quick phase left. If I'm going to drive the eyes to the right into this direction, a slow phase to the right is like a left VOR, meaning that my eyes are going to move slow to the right. I know that the abducens nucleus is going to be involved. And the left head turn uses the left vestibular nucleus. So it's going to come into here. Neural integration step coming to here. And that's going to be a slow phase to the right. My optokinetic stimulation is going to activate what's called the accessory optic system. And it's going to go into the midbrain. And it's going to fire from the rods to the midbrain, down into the vestibular nuclei. And the vestibular nuclei is going to give a slow phase to 6 and allow the eyes to slowly move right. At the same time, it's going to hit a burst, and you have to move the eyes back left. So it's going to then communicate here to these guys, to the burst neurons, which are going to hit here, this guy, and make the eyes move left into the abducens nuclear complex. So the point I'm trying to make is that all slow eye movements are mediated through the vestibular nucleus. All fast eye movements are mediated through the burst neurons. So let's go back to saccades. You do a saccade, everyone here knows the left frontal lobe is going to move the eyes fast to the right cerebellum catches it. But how does that really work? First, I'll draw a cerebellum. There you go, before I start talking about something that doesn't exist. Now, we talked about omnipause neurons are the only things that pause the eyes and inhibit the burst neurons. However, when you have such a fast velocity of eye movements, the omnipause neurons aren't really strong enough to stop the eyes in motion. The way to think about it is your burst neurons are so powerful, the only thing powerful enough to stop a burst neuron to the right is a burst neuron to the left. Meaning that when I saccade to the left, I'm going to activate the right frontal lobe. It's going to come down, left burst neurons, left abducens nucleus, left lateral rectus, right medial rectus. And it's going to move the eyes to the left. And when they get to the left, we all know the left cerebellum is the one that stops it. But how it stops it is the vestigial nucleus fires contralaterally to these other burst neurons. So if I want to stop my eyes from moving right, in this example, if I want to stop my eyes from moving left, I need to temporarily use burst neurons to move it opposite direction. And when I get that pause that's about to move opposite, omnipause neurons come about 15, 20 milliseconds after and stop it. So if you have a vestigial nucleus lesion, you are going to not activate contralateral burst neurons on time. So when you move your eyes to the left, there's a delay in the burst neurons and you get a hypermetria. If you have a dorsal vermis lesion, remember the dorsal vermis has your Purkinje cells that inhibit your vestigium. If those guys are lesioned, you have too much vestigial output. So when I move my eyes to the left, the vestigium fires too quickly and it's going to activate those burst neurons to make my eyes go right. and I'm going to get a hypometria because I'm stopping the saccade too quickly. So if you have a vestigial lesion of the cerebellum, you have hypermetria. If you have a dorsal vermal lesion in the Purkinje system, you'll have a hypometria. If you have a lesion of these burst neurons, the burst neurons give you velocity, you're going to have a slow eye movement. If you have a lesion of the abducens nucleus, and let's say this guy's lesion here, you're going to have a gaze failure to the left. So you're not going to be able to look left at all. It might not be a hemi-neglect, but the fact is that this is your horizontal gaze center, so you're not going to fire to the lateral rectus, and at the same time, you're not going to be able to fire to the medial rectus. Now, if you put the eyes in the rightward direction, you may have some slow movements to the left back to midline because you still have integrity of those muscle stretches that are going to bring it back to middle. But when you go midline to left, it's not going to happen. You have another lesion, which is a 1.5 syndrome that you lesion the abducens nucleus, and you also lesion the opposite MLF. And so what's that 1.5 syndrome is going to give you? It's going to give you a failure to abduct the eye to the left. So you have both eyes can't go left, but then when you look right, your right lateral rectus will go, but you're going to lesion this MLF, so you're going to get an INO, which is an internuclear ophthalmoplegia. So it means that the abducens nucleus is intact and firing, but you lost that middle MLF pathway, so you don't get the medial rectus coming in. You check convergence. Convergence is a mesencephalic center. Both convergence is intact, so you know the medial rectus is intact. It just isn't getting any input from the abducens nucleus. Like I said, I don't want to take too much of your time, so we're just going to go through lesions right now. Vertical centers are going to go up and down. So the top one is the rostral interstitial nucleus and the medial longitudinal fasciculus. That's going to contain excitatory burst neurons. Your upward saccades are very bilaterally innervated. Your downward saccades are bilateral, but they're more ipsilateral. So if you're going to see a lesion in these burst neurons, you're going to see it more on the downward saccades compared to the upward saccades. And the right is more indicative of a right eye down. Left is more indicative of bursting the left eye down. There's some bilaterally, but up is very bilateral. Down, you have more ipsilateral components to it. Down here is your interstitial nucleus saccade. That is going to have your inhibitory burst neurons, but at the same time, that is your vertical neural integrator. So a problem in your vertical neural integrator, what's going to do is you look up, and you're going to get a slow phase down and back up because you can't hold against the resistance to pull back the center. If you look down, you're going to have gaze-evoked nystagmus this way. So lesions of these, at the same time, let me say this. In your midbrain, you have vertical eye movements, but you also have torsional eye movements. Remember, your superior rectus, your inferior rectus, your superior oblique, your inferior oblique, all innervated in the midbrain. And at the same time, all those muscles are both elevators and depressors, but also have a torsion function. So if you look at, let's say this is the left burst neurons of the RIMLF, not only is it going to move the saccades up and down, but you're going to get a left torsion, and it's going to tort the eyes left. This guy is going to tort the eyes right. So the left burst neurons are going to do leftward torsion. The right burst neurons are going to do rightward torsion. That's the way it works. Omnipause neurons are also going to come up here, and they're going to inhibit all these guys. All these burst neurons they inhibit, and they inhibit these burst neurons and these burst neurons, so there's not much different. They're right in that raphe pontus nucleus, right in the RIP, and they're going to be coming up, and they're going to be coming down, and their job is the omnipause neurons is to pause burst neurons. So let's talk a little bit about lesions. Any lesion in burst neurons, you should see slowness of movement. Lesion in the frontal lobe is going to give you a longer latency of your saccades, meaning that on your mark, get set, go, it should take about 200 milliseconds from the target to appear for your eyes to move. Anything over 200 is slow. That's usually seen in a frontal lobe dysfunction. Cerebellar dysfunctions in the vestigial nucleus, you have hypermetria. If you have a dorsal vermal lesion, you have hypometria. If you have a floccular nodule lesion, which is associated with the vestibular system, you're going to have what's called downbeat nystagmus. Reason being is that floccular nodule region has Purkinje neurons, And those Purkinje neurons actually leave the cerebellum and they go to inhibit the vestibular nuclei only on anterior canal pathways. The cerebellum really is the vestibular nuclei that really grew from those nuclei and pretty much grew and pouched back behind the brain and behind the brainstem. So your floccular nodular region is going to go and inhibit pathways with the anterior canal system. So if the floccular nodular is lesioned, you lose inhibition of your anterior canal pathways and you allow for a slow drift up with the fast phase down, and a slow drift up with the fast phase down. Let's talk a little bit about head tilts. I'm going to big up my screen. So to finish off, because like I said, I don't want to keep up too much of your time, we have a lot of videos on the Life Neurology Club where I'm going to go through this slower, and it may be a little easier for me to explain. I wanted to kind of give you an understanding of clinically, to really treat concussions, the more you can localize the lesional area, the better off you be. We're not talking necessarily about a huge metabolic issue. We're not talking about a huge thyroid problem. We're not talking about diabetes, although those could be confounders and those could be involved with your case. We're not talking about a global metabolic issue. A lot of times we're talking about, depending on the concussive force and depending on the situation, everyone's different localized lesions. So the better you can localize a lesion, the better off you can be. So let's look at me, for example, and you look at your eyes and you can see a hypertrophy on the left. And that's usually graviceptive, but if you see a hypertrophy on the left with the left head turn, let's start with the right head turn. So the left eye is high with the right head turn. Your differentials right off the bat are going to be right pontomedullary. The eye is low and the head is tilted to it. So the low eye means the lesion could be low. It could be right pontomedullary. At the same time, if you take a look at a head tilt, it can be a left interstitial nucleus accueil lesion. So a lesion of the neural integrator will give you a ipsilateral hypertropia and a contralateral head tilt. At the same time, a trochlear nuclear lesion is going to give you a similar thing, and a left trochlear nuclear lesion can give you a hypertropia with extorsion of the eye. And the extorsion of the eye is going to create a compensation to tilt the head this way to create some intorsion into it. How do you differentiate it? Well, you could use your ophthalmoscope and you could take a look at the fundus. If that hypertropia is extorted with the right head tilt, there's a chance that is a trochlear lesion, and the left trochlear muscle, or the left superior oblique, is innervated by the right midbrain. So left hypertropia, right head tilt, could be a right mesencephalic cranial nerve 4 lesion, creating a weakness in superior oblique. You could have an interstitial nucleus accueil lesion, which is going to take both eyes. So if it's a left lesion, the eye is going to come up. Oh, where am I? There you go. The eye is going to come up. It's going to intort. Sorry, everything's backwards. And this is going to extort, and the head is going to go this way. So the hypertropia will be intorted on an INC lesion. It will be extorted on a superior oblique lesion. Even more simple. Your INC is your neural integrator. So if you have a hypertrophy on the left with a right head tilt, what you want to do is you want to look at your gaze fixation. If you have a failure of gaze fixation in the vertical plane on top of the head tilt, you can be pretty sure that you have a left mesencephalic lesion in the interstitial nucleus accueil. If the gaze is pretty good, what you want to say is, how good is that neural integrator? You want to check just basic gaze, check the VOR, see if you can hold with your head forward, head back, use a pursuit, use a saccade, use optokinetics, and you're going to take a look and see, can I generate a pulse that's strong enough to fatigue the neural integrator? And if every eye movement and different pulses don't fatigue the neural integrator, you're pretty good to go. It's probably not a neural integrator lesion. If you have a right head tilt with a left hypertropia, it's the eye is low on the right and the head is tilted to it. It could be a right pontomedullary lesion. You want to look and see, do you have IML findings on the right? Do you have oversympathetics on the right? Do you sweat more on the right? Pupil bigger on the right? Is the palate sagging on the right? Muscle tone, your basic pontomedullary reticular formation findings, and you want to correlate those findings with the head tilt. Not so difficult. But as you can see, a head tilt in one direction can mean a couple things, so you want to correlate all your other findings. If I had a head tilt to my left, and this eye is high, and the head tilt is tilted toward the high eye, you want to look pontomesencephalic. Pontomesencephalic, that might be your Doppler, your dento-rubro pallado-louisiano pathway, and you want to take a look at this pathway from the dentate nucleus to the contralateral red nucleus mesencephalic dopaminergic activating system, up into the ventral neostriatum, up into the frontal lobe, back to the dorsal neostriatum, back down into the integrating systems to allow you to move and do your thing. If that's lesioned, you could have different cerebellar signs, different tremors on your left side. So you want to take a real good look. If you have a head tilt with a high eye, what's going on that ipsilateral cerebellum? What's the tremor like on that side? And you want to take a look to localize that lesion. So I'm just going to run through real quick some of these slides. So here's our different types of saccades. We have volitional saccades that are going to go to purposeful behavior, predictive saccades are anticipation, memory-guided saccades where you generate to a location where the target was but it's not there anymore, anti-saccades where a target pops up and you look at an equal and opposite target on the other side, reflexive saccades, which are quick phases of nystagmus, express saccades, which uses a gap stimulus. So if I have my finger here and I go back and forth, the target is staying in the same position. If you look at the Carrick brain exercises, one target disappears, another one reappears. That's a gap stimulus. That's an express saccade. That's very indicative of what the superior colliculus does, and you should have a shorter latency than a volitional saccade. That's what that means. We didn't go too deep into that. We're not going to. So different lesions are going to give you premotor burst neuron lesions, slow saccades. Motor neurons, ocular motor nerves, you could have a slow saccade if it's subtle. If it's bigger, you could have a limited range of movement, like we talked about with the abducens nucleus. Your RIMLF is slow vertical, PPRF slow horizontal, like we talked about. Omnipause neurons, those inhibit burst neurons, and those are going to give you saccadic oscillations. Cerebellar dorsal vermis is going to give you hypometria of saccades. Your fastigial nucleus is hypermetria. Your colliculus, superior colliculus, is going to lose those express saccades, which we didn't talk much about, but that's what it's going to do. And then your thalamus, inaccurate double step, which we're not going to talk about in this lecture. And then parietal eye fields are going to impair your visually guided saccades and your memory saccades. Your frontal eye fields are going to increase your latency to saccades and overlap stimulus, which is overlap is when one target doesn't disappear and the other one you go to a new target. In the real world, you really only have overlap saccades. These express saccades, realistically, things in the real world don't vanish, more or less. So it's really a good test to look at the superior colliculus, but it's not so much functional day-to-day activity. So here's your pulse and here's your step. Here you go, your frontal eye fields. They're going to come down to the superior colliculus, and they're going to cross over to the opposite PPRF, which is going to fire the ipsilateral abducens nucleus and make the eyes move. Here's your omnipause neurons, and they're going to inhibit all of your burst neurons. Here's a little cool picture of your PPRF is here. Your rostral interstitial medial longitudinal fasciculus is in here. And nice little brainstem picture. So let's just finish this off right now. And you have the PowerPoint. My goal is that you could look at that PowerPoint and you're going to be able to go through that PowerPoint and really understand the details that I went to make the PowerPoint without me having to spend too much time walking you through it. Hopefully I gave you a little background or baseline information of eye movements. So now what I want you to be able to do is when you look at, let's say, a gaze fixation to the right, and you see a square wave jerk where you have a quick phase fast, a pause, and a quick back, I want you to be able to say, burst neurons are firing inappropriately. If you see a slow movement, if I'm gaze fixating, a slow movement in and a fast phase out, I want you to say, that was a slow eye movement. That could be a neural integrator off the pull, or if you have a nystagmus, you want you to think of the vestibular nucleus. To repair pursuits and rehab pursuits, I want you to start thinking, I can use a VOR reflexively because the pursuit hops on that VOR train to allow the eyes to move slow. At the same time, a saccade is a fast movement. It's going to hop on those burst neurons in the brainstem and allow those to move fast. Your omnipause neurons inhibit all eye movements that shouldn't be there. So for me to look straight at the camera, my omnipause neurons are inhibiting all my eye movements to make my eyes go in any other direction. Your vertical eye movements and your torsional eye movements are mesencephalic, and they're going to be the RI-MLF, the rostral interstitial nucleus of the MLF, medial longitudinal fasciculus, are going to give you burst neurons. They're going to do quick phases and saccades up and down. And then the right MLF, RI-MLF, is going to do right torsion. The left is going to do left torsion. Your paramedian pontine reticular formation and your PMRF, your pontomedullary reticular formation, is going to be more horizontal eye movements. Your burst neurons are quick, they're burst, so if they're affected, you're going to have slow eye movements. Your neural integrator holds the eyes in position. If they're affected, you're not going to have good gaze stability. You want to work through a paradigm where you start with gaze stability, and then you go up reflexively. How's your VOR? How's your optokinetic nystagmus? How's your smooth pursuit? How's your saccade? And then you're going to be able to do rehab where if I have right square wave jerks, and my right burst neurons are always firing, maybe I want to activate my left burst neurons to oppose those. So maybe I do left saccades. Maybe I do a right OPK that's associated with the left burst neuron with the quick phase. If I want to really work on my pursuits, I could use VORs, I could use 2x viewing, I could use slow phases of nystagmus, but I can start overlaying my treatment based on my understanding of how the eyes move, what the pathophysiology looks like, and how things work together to allow me to start localizing and saying, you know what? The person can pursue to the right and left really well. Their optokinetic slow phases are really good right and to the left, but when I do a left OPK, my eyes stay deviated to the left, so my right quick phases aren't so hot. When I do saccades, my right saccades are a little slower than my left saccades, but my gaze holding is all great. And then you're going to say, my VOR is good, my pursuit is good, my slow phase is good. Everything that runs through that vestibular nucleus is pretty cool. My quick phase is a little bit slow. My saccade is a little bit slow. I'm a little worried about these premotor burst generators and the PPRF on the right side that was in that example. I want to take a look at what their right PMRF findings are, what their autonomics look like on the right side compared to the left, and I want to really localize into that region. And because that, in order, if you look at my VOR, I'm going to go up and down. That's through the vestibular nuclei, but the vertical eye movements are going to be up in the midbrain. So it has to come from the ear, down the pons, up that medial longitudinal fasciculus and that ventral tegmental tract, up into the midbrain. So this is going to give me a good indication if that's intact, that middle brainstem is looking pretty good. If my saccades aren't great in the vertical plane, I'm looking at burst neurons. If my saccades are really good, but my pursuits and my slow phase, my VOR is not intact, I'm looking at something more with that vestibular nucleus. I'm hoping that this is going to help a little bit and bring some light into eye movements and how you could use it a little bit diagnostically. Obviously, in 50 minutes, this is, for those in TBI, know that we've spent 400 hours-ish already on this topic, and I try to do my best to give you the basics in about 50 minutes. Hopefully this was helpful, and hopefully this wasn't a complete waste of time or a complete blur, or I didn't go too fast. I didn't want to take up too much of your time. Big picture. You could really use eye movements diagnostically to really help you localize the lesion. Because eye movements are such a good window of different functions and different areas of the brain, you could really use them very, very functionally and very well to localize different parts of the brain and develop a better treatment protocol. If you take a look what we're doing at the CBC in Atlanta and in Dallas, we very, very carefully at eye movements, understanding that these eye movements are very sensitive functions, but they might not be the most specific because at the end of the day, these neural neural networks. So you can still have a frontal lobe lesion that gives you a diastasis of cerebellum looking like a cerebellar lesion. So you really need to do your physical exam and say, what's my DDK versus what's my finger tapping? What's my hypomemia scale? What's my gait look like? What's the arm swing look like? What's my center of pressure looking like? What's my autonomics looking like? What's my finger to nose looking like? And you need to take your eye movements as a very sensitive indicator of a neural network. And you need to overlay that on your physical exam, which is going to be more specific to different areas of the brain. So you overlay all these diagnostics that you're going to be doing with your VNG, with your saccadometer, with your CAPS, with your Neurocon, whatever you use. But you can't just look at that because it's all a network. So different areas of that network give you similar findings. So you need to use your physical exam to localize the lesion, make sense of the diagnostic eye movements, and use them as a sensitive indicator of how your therapy is doing and how you're going to get a person better. Life University, the CBC in Atlanta, I don't know if there's a better place to learn functional neurology and be in functional neurology right now than in Atlanta, Georgia. Every Thursday night, we have a functional neurology club. Every Wednesday night, we have the advanced neurology club. And now every Tuesday night, we're doing the neurology roundtable, where we are going to sit down with people in the area. We're going to watch a case study of Dr. Carrick during grand rounds, and we're going to write it up as a full case study that'll be published in a major medical neurology journal. Then we also have the Carrick Brain Center right here. So I know great things are happening in Australia, great things are happening in Dallas, and this functional neurology hopefully is going to continue to expand. And I hope I gave you a little bit of a window in what's going on in New Atlanta, the level that we're at in Atlanta as far as looking at eye movements and trying to localize lesions. And hopefully I helped someone, and hopefully this wasn't too basic, but hopefully I helped a little bit of trying to at least have a basic understanding of how to look at these different type of eye movements, how to localize them in the brain, how to come up with a diagnosis of where the lesion is, and how to develop a little bit of an idea of treatment protocols of if I have a nystagmus with a slow phase up and a fast phase down, maybe my treatment is using a treatment that has a slow phase down and a fast phase up, and how I can offset these central networks in the vestibular system to give the person a better functionality of their brain to help reduce symptoms and get them back into their life. So thank you very much for this time. I very appreciate, I'm very humbled to be on, and I'm honored to even be asked to be a speaker here because I'm not so pretty recently graduated. But like I said, this functional neurology is just so beneficial, and I've seen it help so many people that me myself, I put a lot of work in as a student to get to where I'm at now, and I still have a long way to go. And there are a lot of students behind me that are doing the same thing. And hopefully, especially in the world of concussions, we're going to have an army of people who could really do a good physical exam, read the diagnostics appropriately, come up with a good diagnosis, come up with a good management plan, and just change people's lives. Because right now, there's nobody that could do work, especially in concussions, the way that we can. And I say that as somebody who's watched Dr. Carrick for 3 years now and been right next to him for 3 years and seen the best people, best top athletes, presidents of medical schools get better with us. And they've been everywhere. Usually the average is 19 to 21 doctors before they come to us. And I've seen our results doing our activation, very specific brain activation, just get better results than everyone else. At the same time, I've seen hyperbaric chambers, I've seen people with deep brain stimulation, I've seen other therapies that were not as effective without doing the neurology and neuroplasticity first. So my suggestion to you is really to focus on localizing a lesion, creating focal proto-oncogene expression through activation, through specific activation. Oh, sorry about that. Through specific activation and allowing more stability in these neurons, allowing to take off some pressure of the mitochondria, a little more stability in the system, and allowing for just stability and health in the neuron, which is going to not only create a more stable person, but allow all other therapies, if that's what you plan on doing, to work better. But what I could tell you is when it comes to concussion, I don't think there's a therapy that works as good as a specific receptor-based activation into the area of problem. Thank you very much. I hope you all have a great conference. I know you've got some great speakers. Again, thanks to Dr. Brock, and thank you for Danielle for this opportunity. Obviously, thank you, Dr. Malillo. Thank you, all the teachers. And thank you, Dr. Carrick and Trish, because without them, I wouldn't have this opportunity to be here with you right now. So thank you so much, and I hope you all have a great weekend.